For those of you who don't know me, my name is John Susa. I'm one of the obstetricians and gynecologists at Hudson Physicians. Thank you for coming. I appreciate your support and interest in the topic tonight. As you guys know, tonight's presentation is being taped and recorded for the website. So, without further ado, we will get started. Tonight's topic is on abnormal uterine bleeding, and really, what are my options, or what are your options as far as dealing with abnormal uterine bleeding? The objectives of tonight are going to be the following. We're going to define really what is normal menstrual bleeding, what's considered abnormal menstrual bleeding, and what's considered heavy menstrual bleeding. We're then going to review some of the reasons why a woman may have abnormal uterine bleeding, as well as learn about potential diagnostic testing and explore the 5 most common treatment options for irregular or heavy bleeding. Well, to define normal, it's hard to define abnormal without first knowing what normal is. And the normal menstrual cycle is considered to be typically between 24 and 38 days in duration. A normal menstrual period will typically last 8 days or less. So anything more than 8 days is considered abnormal or heavy, and anything outside of the 24 to 38 days is considered abnormal. So when we look at the definition of abnormal uterine bleeding, really, again, it can refer to either the quantity, the duration, or the schedule of the bleeding. It falls outside of that 24 to 38 days, or if it falls outside of the quantity, meaning heavy or light. Luckily for us, not luckily for us, abnormal uterine bleeding happens in approximately 10 to 35% of women. What I was going to say is, luckily for us, heavy bleeding has recently been redefined. The old definition of heavy bleeding used to be more than 80 milliliters of blood loss during a menstrual period. Well, who's collecting their blood and measuring it? Nobody, right? So they've changed the diagnosis really to just being excessive menstrual blood loss, which interferes with the woman's physical, social, emotional, or material quality of life. So really, the definition is personal. The definition is what the patient considers to be excessive. What are some signs of heavy bleeding, or what could one use to kind of judge whether or not her menstrual cycle is heavier than normal? So we always ask, how many pads or tampons are you soaking or going through? And really the answer is usually typically 1 to 2 an hour. Once we get to 1 to 2 pads or tampons an hour, lasting for several hours, then the cycle is a little bit heavier than what could be considered normal. Needing to use both a pad and a tampon or something, again, that we look for as far as quantifying how much blood loss there is. Needing to wake up in the middle of the night to change a sanitary pad. Bleeding for longer than a week. Passing blood clots larger than a quarter. And this is the one that I think is probably most important. Restricting daily activities due to heavy menstrual flow. So if your period is interfering with your lifestyle, if it's interfering with what you want to do for the day, then it is most likely heavy. Some of the physical symptoms that one can get from having heavy bleeding are really a result of anemia. So anemia, feeling tired, fatigue, shortness of breath, those are all a sign that there's significant blood loss leading to decreased oxygenation within the cells and subsequently feeling tired. Lots of causes of abnormal uterine bleeding, and we're going to go through a few of those today. Kind of the more common ones, or the things that we think about that we see more often in the office, would be uterine polyps. We're going to go through each one of these individually. Uterine fibroids, adenomyoses, dysfunction of the ovaries, and then perimenopause. What are uterine polyps? Uterine polyps are really growths that develop within the kind of the membranous tissue of the uterus, or within the endometrium. The endometrium is the lining of the uterus, and you can see in this slide here there's 2 polyps kind of within the uterus. Uterine polyps are small, they're usually fluid filled, almost like a little grape, I would say. They would have kind of an increased blood flow to them. They can easily bleed if they are touched or disturbed. And so a lot of time women with polyps will have bleeding in between periods or irregular periods as a result of the polyp. Sometimes the polyps can actually be found near the uterine cervix. And if that's the case, we'll sometimes see bleeding with intercourse, or again, just bleeding in between periods. Uterine fibroids are another reason for heavy bleeding. Fibroids are, for lack of a better word, I like to say that fibroids are a tumor, but when we think of tumor, we think of cancer. Fibroids are not cancerous, only in very rare situations. Fibroids are rather benign or non-cancerous growths that form within the inside of the uterus. They can really be found in multiple places on the uterus. And again, this picture kind of demonstrates that. The fibroids that really cause problems are the ones that touch the endometrial lining of the uterus. So you can have fibroids on the outside of your uterus, you can have fibroids within the muscle wall of the uterus, or you can have fibroids that actually touch or distort the inner lining of the uterus. And those are the ones that will cause heavy bleeding, largely because, again, they have an increased blood supply. Adenomyosis. Adenomyosis is a condition where, again, the cells that are supposed to be found on the inside of the uterus or within the endometrium are found within the muscle layer of the uterus. And so, again, as this picture demonstrates, these cells are within the muscles and they get stimulated just like the endometrium does. And so what happens is women will oftentimes have more painful menstrual cramping when they have adenomyoses. They are more likely to have increased pressure and bloating, as well as heavy periods. Probably the most common reason or thing that we see as a reason for heavy bleeding is just what we call ovulation dysfunction or hormonal imbalance. And really it's hard to understand hormonal imbalance without kind of understanding what the normal menstrual cycle is. So that's what this slide demonstrates. Again, I feel like it took me 4 years of medical school and 4 years of residency before I finally understood kind of the estrogen and progesterone and how it applies to the menstrual cycle. But this slide does a pretty good job of demonstrating it. Really, the first day of bleeding is always what we consider to be day one of the cycle, right? And so then what happens is within the ovary, an egg develops, right? So it's stimulated by the brain, an egg starts to develop, and that egg produces a hormone called estrogen. Estrogen then stimulates the lining of the uterus to grow. About halfway through the cycle, the egg will be released, and once that happens within the ovary, a small cyst is formed, called the corpus luteal cyst, which then produces a different hormone called progesterone. Progesterone then keeps the lining of the uterus thin, or I should say stable, and of course the sole reason being that it's awaiting fertilization of the egg. Of course, every month fertilization doesn't occur, and when it doesn't occur, both the estrogen level and the progesterone level decline, and once they both decline, then menses starts. So the classic example where I tell people think about again a birth control pill, which mimics the menstrual cycle. You're taking both estrogen and progesterone for 3 weeks, right? And then the last week is that week of no hormone. So it's actually that drop in hormone which stimulates the menstrual cycle to begin. Sometimes, however, the menstrual cycle doesn't go as planned. But one of the more common reasons why that happens is what we call anovulation. One of the more common reasons for anovulation is something called polycystic ovarian syndrome. So this picture here kind of demonstrates what we call a polycystic ovary. And so think about basically the ovaries being stimulated, the follicles are forming, but they're never being released. And so what happens is you get stuck in the middle of the cycle, right? And so you go through one cycle, you kind of get stuck, and you have this follicle that's not released, and when it doesn't get released, not only do you not get pregnant, but then you don't get to the progesterone phase of the cycle. And so you get kind of this buildup of ovarian follicles, which all produce a small amount of estrogen, and then that estrogen causes the lining of the uterus to grow. As the lining of the uterus grows, it fills up the cavity of the uterus, and then you start to have irregular bleeding. Almost what I would consider to be what I like to call overflow bleeding, meaning that the tissue grows so much that the uterus just can't sustain it and it starts to flow out. So people with polycystic ovarian syndrome or people who are anovulatory will often come in and complain and say, I didn't have a period for 6 months, and then all of a sudden I've been bleeding for the last 3 weeks. What's going on here, right? Basically their uterus filled up, it's overflowing, but they're not getting that normal menstrual period where it just cleans out and starts over. Perimenopause. Perimenopause is a condition that we see a lot, and again, a lot of women who I'll see in the office come in this perimenopausal stage, which really is different for everybody, but generally speaking, from 45 to 55 years old, it's that time of a woman's life where she goes from having normal, regular, physiologic cycles to menopause, right? It's that transition between the two. And again, I like to use a lot of analogies, as you guys can already tell, but the analogy I like to use for perimenopause is imagine your uterus is a clock, right? Imagine your uterus is a clock, and the batteries that run the clock are your ovaries, right? And so, obviously I found a picture of a clock on Google, right? And I sometimes tell people, I'm sure you can find it on Google, right? People ask me about a side effect, and I'm like, I've never heard of that, but I'm sure you can find it on Google. Well, when I was surprised at just how many uterine clocks I could find on Google, I was like, okay, well, clearly you can find anything on Google if you can find that many uterus clocks. But imagine your ovaries, imagine that within the clock, the batteries are your ovaries. And again, in the normal reproductive age female, the batteries are working just fine. We have a full battery level. Things are happening regularly or normally. Contrast that to somebody who's in menopause, where the batteries have run out. Also not a problem, right? We know what to expect. There's no bleeding. There's no hot flashes or night sweats. Everything's already happened, right? It's done, it's completed. The problem is that transitional period between full battery and empty battery, and that's what we call perimenopause. It's during that perimenopausal state that you look at the clock and you say, it says it's 6:45, but I think it's really 5:30, right? It would be worse if it would be better if it was just completely stopped or if it was keeping time, but we look at the clock and we have no idea if it's right or it's wrong. Everything is just completely dysfunctional because, again, those ovaries are starting to wear down. What are some of the different diagnostic tests that we can do in the office to determine what exactly is the cause of the bleeding, right? So there's a number of things we can do, and it's really going to be individualized between you and your provider as far as what tests are appropriate for you. But certainly things like laboratory tests, pelvic ultrasounds, hysteroscopy, which we'll talk about, and endometrial biopsy are all potential testing options that we have. Laboratory evaluation, there's several different things we can do, such as check a hemoglobin level, right? Hemoglobin is the molecule in your blood that carries oxygen. And if a woman has had chronic heavy bleeding, oftentimes she will be anemic. And so one of the things that we certainly check is just the hemoglobin level. There are sometimes people can have an underlying bleeding disorder, which causes them to bleed more readily or inhibits their ability to clot. And so occasionally we will check different things within the blood that kind of are part of the clotting cascade. Thyroid is a common issue that we see. Having a hypoactive thyroid is incredibly common among females. The thyroid really doesn't have much to do with the ovaries. However, within the pituitary gland, which stimulates the thyroid, the pituitary gland also stimulates the ovaries. And so if the pituitary gland is working extra hard to stimulate the thyroid, it's probably also working extra hard to stimulate the ovaries at the same time, kind of by default. And so oftentimes by correcting a thyroid level, we can also help to regulate cycles. Finally, hormones. Everybody asks, Doc, can you check my hormones? And the answer is yes, we can check them. The unfortunate truth is that it's usually not very useful. And it's not very useful for a couple of reasons. Number one, what your hormone level is today is probably different than what it's going to be tomorrow, or what it's going to be different than it is 3 days from now. And so to just check it today, when the cycle is constantly changing, isn't incredibly valuable. The other problem is that there's such a wide range of normal with hormones that almost ultimately your hormone level is going to fall within the normal range. unless you're, menopausal or unless it's a rare situation, people are almost disappointed that when they get their hormones checked, it comes back and it's normal. It may not be normal for you, but it's going to fall within the laboratory range of normal. And so in medicine, we kind of have a saying, treat the patient, not the lab. And so if you come in and tell me that your periods are all over the place and that you're having hot flashes and that whatever symptoms you may be having, we may know that your hormones are abnormal. We don't need a lab to tell us that. Or the same is true as if your periods are completely regular and you don't have any issues, then drawing your labs to prove it, or even if the lab falls outside of the normal range, it doesn't change what we're doing clinically. So the honest truth is that we don't often check hormones in regards to irregular or heavy bleeding. It can be done. Pelvic ultrasound. Pelvic ultrasound is a valuable tool because obviously it rules out a lot of the things that we talked about earlier as far as reasons for heavy bleeding. So we talked about uterine polyps and we talked about uterine fibroids and adenomyoses. Here we have a pelvic ultrasound, and again, sometimes we look at these things and we say it looks like a bunch of shades of gray, but I'm going to just try to explain it to you briefly. In this ultrasound, again, here's where the probe is, right, on the patient's abdomen, and this would be the bladder. So anything clear or black is basically clear fluid. And so here we can see the uterus, and then within the uterus there's this white stripe. So this is a completely normal uterine ultrasound. So what's not normal? Well, here again I have a normal uterine ultrasound. Here we have the uterus. There's a nice thin white line. That's that inner tissue that grows and sheds every month. Here you can see on this picture that the tissue is significantly thicker, right? So this is a patient that probably has excessive estrogen or is ready to have a cycle. There's our normal range for everything, of course, between 5 and 15 milliliters or millimeters. If we were to actually measure it, is considered normal in a reproductive age woman. Uterine fibroids we talked about. Again, here's just a couple of pictures of uterine fibroids. So here we can see there's a large, this is a normal uterus, and we can see a fibroid here. And the same, here's a fibroid that's actually going into the cavity of the uterus, which again, these are the ones that cause the heavy bleeding. Same is true for uterine polyps. Here we can see little polyps within the cavity of the uterus, and then again, this could either be a fibroid or a uterus, to be honest, within that a fibroid or a polyp, within the uterus. Sometimes the problem is actually the ovaries, right? The ovaries make the hormones which tell the uterus what to do. And so in these pictures, we just have a picture of an ovary here on the left with a big, simple ovarian cyst. That cyst may be causing the ovary to not function normally. So that would be taken into consideration. And here we have what we consider kind of the classic polycystic ovarian syndrome, just like we talked about. If you're making a little follicle and you're not ovulating that follicle every month, then you'll get you'll only get a bunch of follicles in your ovary. It's classically referred to as the chain of pearls, or string of pearls. So you can see how it looks like the ovary's wearing a string of pearls. Sometimes we say chocolate chip cookie, but I believe that's a string of pearls, I guess. This is a baby. It has nothing to do with what I'm talking about, but just thought it was a good ultrasound. Hysteroscopy. Hysteroscopy is another potential both diagnostic as well as treatment option. So this is a hysteroscope. Hysteroscope is a procedure where basically we take a camera through the vagina, we enter into the cervix, and then we look inside the uterus, okay? This can be done in the office or it can be done in the operating room. These are just two pictures of what it actually looks like if you were to look inside of the uterus. On the right we have a polyp, and then on the left it looks more like a fibroid. So through the hysteroscope, again, we can make a diagnosis, but we could also potentially remove these two things to treat the irregular or the heavy bleeding. Endometrial biopsy. This is important because, of course, if somebody comes in and they're having heavy or irregular bleeding, unfortunately the first thing we always think about is worst case scenario, right? And oftentimes people will come in and we'll talk for 20 minutes and then they'll say, so you don't think it's cancer, doc? And I'd say, well, I wasn't really thinking that it was, but the good news is the good news is we can rule it out. And how do we rule out cancer? Well, the easiest way to do it is with an endometrial biopsy. And an endometrial biopsy is a procedure that can be done right in the office, same day as your visit, where basically, again, we look at the cervix, and then we introduce a small straw-like instrument into the uterus. The straw has suction behind it, and it just sucks up some of the tissue. We then send that tissue to the pathologist, and the pathologist sends us back a report, usually in about a week, and tells us that, hey, this is just normal tissue. Sometimes they'll say it's unsynchronized tissue, meaning, again, that it's in all different phases when it should all be in the same phase. Sometimes, unfortunately, they'll come back and say these are precancerous cells, or that they're even cancerous cells. Of course, if it's precancer or if it's cancer, then that changes what we're doing, that changes the treatment plan, that changes the options. Let's talk about those treatment options. So again, the goal of treatment is to control the bleeding, it's to treat the anemia if it's present, and to restore quality of life. There's lots of different things, as we talked about, as far as how do we determine which treatment option is best for you. First of all, we have to know why, right? Why is it happening? Why is the bleeding occurring? Especially important, what are your plans for future pregnancy? Half of my patients are desire future childbearing, and the other half of my patients will say, I'm done, 100%, no doubt about it. The patient's age obviously makes a difference when we're talking about treatment options. The severity of the bleeding comes into play. Other associated symptoms, such as are you having painful bleeding, are you having painful cramping, are you having pain before the period starts, after the period, etc. Family history is important. Did your mom have ovarian cancer? Did your mom have uterine cancer? Does your sister have Did your sister have a hysterectomy for various reasons? So that also comes into play. Medical comorbidities are important. Sometimes not all treatment options are available to everyone because of other medical conditions. For example, some patients can't get estrogen because they have a blood clotting disorder. Risks for surgery. Do you have any risks for surgery? Are there any reasons that you are a good surgical candidate or not a good surgical candidate? Again, we'll kind of go through these things more specifically. Cost. You know, in medicine, I always say that really cost is not an issue, and that doesn't mean that it's not. We like to treat everybody as if cost isn't of concern, but in the world that we live in, unfortunately, it is. And with deductibles being high and with people having to pay a lot of money out of pocket, sometimes cost does come into play. And then most importantly, patient preference. You know, as a patient, what is best for you? It always amazes me. We can have two patients the same age, almost everything is identical, and one will choose to do something very conservative, and the next patient will say, take out my uterus. It's really patient dependent on most of these things. Before we talk about more specifically kind of the treatment options, I just want to be clear that what we're not talking about when we talk about bleeding, that these treatment options we're going to discuss really don't come into play if we're talking about acute uterine bleeding, meaning somebody's actively hemorrhaging. If the bleeding is caused by a blood clotting disorder and it's not really of gynecologic nature, if the bleeding is caused by other medical issues such as liver or kidney disease, bleeding which is secondary to cancer or precancer is obviously treated differently. Bleeding in pregnancy or postmenopausal bleeding. These are all things that need to be individually kind of assessed and analyzed and discussed with your provider. And so the following treatment options don't really apply to these things. Option number one, observation. You know, again, I think it's important. It's always important for me that my patients know that we don't have to necessarily do anything, right? And so people who come in to see me, they're probably already past the observation stage. They've already been doing observation for 1 month or 2 months or 10 years. But I always tell them, look, if we can rule out the serious stuff, if we know it's not cancer, if we can figure out what it is, if you're having irregular bleeding, but you're not anemic, we don't have to do anything, right? We don't have to have surgery. You don't have to have hormone. Very few people die of heavy vaginal bleeding, right? Or very few people have their life shortened or or whatever. The quality of life, of course, is an issue, but observation is always an option. What are the advantages of observation? It's all natural, right? A lot of people will say, I want to do what's most natural. Well, doing nothing is the most natural. It's what's happening naturally. It's non-invasive, meaning there's no risks of surgery, there's no risks of hormones, there's no risks of intervening. And the truth is it's relatively inexpensive. I mean, other than just kind of the expense of more pads, more tampons, and things like that, there's not a lot of expense to continuing with observation. What are the disadvantages of observation? Well, of course, it's disruptive to your lifestyle. There's a reason why you came to the gynecologist in the first place. It's because you're done with observation. It's disrupting your lifestyle. It's disrupting your quality of life. There's always a risk that if we do nothing, that it's going to get worse. There's an emotional toll of not knowing what the future holds, right? So you never know. Is the next period going to be the one where you do become anemic? Is the next period going to be the one where you have to go to the emergency room? Is the next period going to be the one where you pass out on the bathroom floor? The other disadvantages of observation are that it might require you to have frequent labs to monitor for anemia, and it may require frequent endometrial biopsies to make sure that we're not missing something more serious like cancer or precancer. Option 2, estrogen and progesterone therapy. Really, in all honesty, when we talk about estrogen and progesterone therapy, what we're talking about is the birth control pill or oral contraceptive pill, right? So estrogen and progesterone come very neatly packaged in an oral contraceptive pill. It's cheap, it's paid for by insurance, and so oftentimes this is an option that people are familiar with and choose to proceed with for their heavy bleeding. How does estrogen and progesterone work? Well, again, remember that estrogen and progesterone are the two hormones that occur naturally. And so by taking them artificially, what happens is your estrogen level is artificially high, and that tells your brain not to stimulate your ovary, that you already have enough estrogen. And so when it doesn't stimulate the ovary, then an egg is not produced. When an egg isn't produced, of course, number one, you can't get pregnant, but number two, the amount of estrogen made by the ovary is decreased, or it doesn't occur. And so overall, it seems strange, but you take a pill of estrogen to actually decrease your overall estrogen level. With a lower estrogen level, then the lining of the uterus will grow less, the endometrium is less stimulated, and so people who are on the pill will typically have lighter periods, and they'll also have much more regular periods because, again, 3 weeks of active pill followed by 1 week of no hormones, and that 1 week of no hormones stimulates menses. Advantages of the pill: periods are typically lighter, they're more regular. With lighter periods comes reduced uterine cramping. Pill is minimally invasive, meaning again there's no risk of surgery. It's as easy as taking 1 pill a day. Relatively inexpensive because it's typically covered by insurance. Studies show that women on the pill will typically have a 35 to 69% reduction in their overall blood loss. The pill can be stopped if pregnancy is desired, or it can be easily changed if the particular pill you're taking isn't as effective as you want it to be. Of course, there's disadvantages to the pill as well. It requires taking a daily pill, which is oftentimes difficult for people to remember. And so, unfortunately, if you don't take the pill on a regular basis, it can cause irregular bleeding as much as it can prevent heavy bleeding. Multiple trips to the pharmacy every month to pick up your pill pack. You know, most pill packs start on a Sunday, which was a terrible idea by whoever invented it, because you run out of take your last pill on a Saturday night, and then you realize that you don't have any pill for Sunday, which of course is when the pharmacy is closed and your doctor is out of the office. There are some unintended side effects of taking a pill occasionally. Sometimes people will complain of bloating or just not feeling good. Nausea is a common side effect of taking the pill. The pill is not always effective. It affects your hormone levels, and some women the pill is contraindicated. just briefly, who's not really a candidate for a birth control pill? Women over 35 who smoke, women who have high blood pressure, women who really have any significant risk factors for cardiac disease, women who have migraine headaches with an aura are at an increased risk of stroke when taking the pill. If you have other blood clotting disorders, the pill may not be for you. And of course, anybody with a history of either cancer or precancerous cells in their uterus, we don't want to stimulate that cancer by giving you artificial estrogen. Option number 3, long-acting progesterone. So progesterone is, again, one of the 2 hormones that are kind of naturally run the menstrual cycle. And so where estrogen causes the lining to grow or to be stimulated, progesterone kind of says, hold on, let's stay still, right? And so progesterone works very well for kind of long-term use at keeping the lining of the endometrium thin. And really, to be honest, what we typically talk about when we're talking about controlling bleeding is right here, what's called an IUD, or a Mirena IUD specifically. So you can get a shot of progesterone, very common amongst older teenagers as a form of birth control. You can take a pill of progesterone, but the IUD, how it works is it actually contains progesterone within the plastic body of the IUD, and slowly over the course of 5 years, it secretes that progesterone into the uterus. The progesterone keeps the lining of the uterus thin, and so most women who are on the IUD will have either significantly lighter bleeding or will not have their period at all. The advantages of the progesterone, and specifically of the IUD, is that it's easy to administer. You can come into the office, you can have your consult, you can tell your doctor you have heavy bleeding, and you can walk out of there 5 minutes later with an IUD already in place. No surgery, no trip to the pharmacy, nothing, done. There's a 71 to 95% reduction typically in menstrual blood loss with the IUD. Many patients will stop getting their periods altogether with the IUD. The IUD is good for 5 years, and the progesterone of the IUD also significantly decreases your future risk of precancerous uterus, of cancerous cells within the endometrium. Disadvantages of the IUD. Unfortunately, one of the common side effects of progesterone is that women will have irregular bleeding or spotting. So whereas a birth control pill will have a regular cycle every 4 weeks, progesterone kind of prolongs menses or stops menses, and as a result, it's much more common to have breakthrough bleeding. IUD is contraindicated in women who have uterine abnormalities, or kind of if you have an odd-shaped uterus, if the uterus is flexed one way or the other, or if it's not a normal size or shape, then the IUD is probably not the best option for you. The IUD needs to be replaced every 5 years. And in very rare cases, the IUD can perforate the uterus, usually at the time of insertion, meaning that surgically it has to be removed. Option number 4, endometrial ablation. So the first 3 options we talked about, observation, oral contraception, and long-acting progesterone, those are all completely reversible options that can be used in anybody who wishes to maintain their ability to have children or get pregnant. Final 2 options, endometrial ablation and hysterectomy, are completely opposite. They're both permanent, and they both eliminate any option of future pregnancies. So endometrial ablation, what is it? Endometrial ablation is a procedure that basically surgically destroys the inner lining or the endometrium of the uterus. And so if you recall my previous analogy with the clock and the batteries, so the uterus is still being stimulated by the ovaries. It just doesn't have the ability to respond anymore. Remember, the ovaries are still functioning. They don't know that the lining of the uterus is destroyed. But it just doesn't have the ability to grow tissue any longer. This is from a brochure of the NovaSure procedure, which is just a brand name of one of the endometrial ablation procedures. So how does it work? Again, basically what happens is within the operating room, take you to the operating room, Anesthesia is involved. You'll get an IV. Patients will fall asleep. Then we carefully insert the device into the uterus. The size of the uterus is actually measured. The device settings are made. And then there's basically a piece of mesh which comes out and fills up the cavity of the uterus. Once the device settings are made and all the safety checks are done, then over the course of about 90 seconds, that piece of mesh will heat up. As it heats up, it just cauterizes the blood vessels on the inside of the uterus. So again, by cauterizing those blood vessels, it basically makes that tissue non-responsive to any hormones. That cauter takes about 90 seconds. Once it's completed, the device is removed, and it really, again, leaves the inside of the uterus cauterized. This is a picture. It's not a good one, but all that's really important is you can see the difference, right? So pre-treatment, when you look inside the uterus, it's pink, there's blood vessels, it's red, there's lots of tissue. After 90 seconds of cauterization, you can see those blood vessels are no longer present. So that tissue just doesn't have the ability to respond. Advantage of an endometrial ablation, it's a great procedure. It's done as a same-day procedure. You come into the operating room, the procedure takes 5 minutes, you go home the same day. I mean, most people come in the morning, they're home by about lunchtime. Minimal recovery. Most patients return to work after about 1 to 2 days. 93% of patients are satisfied with the results of their endometrial ablation procedure, which means that 7% aren't, but 93% of people are. And 40% of patients will report no bleeding after the procedure. So, I mean, if you do the math, obviously, approximately 40% will have no bleeding, but 53% of people will still have some period or some bleeding. It'll just be significantly lighter than what they had previous to the procedure. Disadvantages of the endometrial ablation, there's no guarantee, obviously, that the bleeding will stop. Again, 7% of patients are not satisfied with the results. It's still an operative procedure, so you have the risks of surgery and the risks of anesthesia, although those risks are pretty minimal. In rare cases, surgery can't be completed. So again, in rare cases, the machine may not work, the machine may not fit your particular size or shape of the uterus. There can be complications, which would mean that the safety checks aren't able to be passed. So it's always an unfortunate situation when somebody has to wake up and then you have to tell them, I'm sorry, but we couldn't complete the procedure, right? And then we have to talk about what the other options are. So, doesn't happen very often at all, but it can certainly happen. Other disadvantages are that if we destroy the uterus's ability to bleed, then potentially we delay its ability to tell us that something is also wrong, right? And so one of the first signs of endometrial cancer is abnormal bleeding, and if we destroy the ability to bleed, an endometrial ablation theoretically could delay the diagnosis. It's important to know that an endometrial ablation is not a form of contraception, meaning that you have to have some other form of contraception. We don't want a woman to get pregnant after an endometrial ablation has been performed. So typically people will say, oh, my husband's had a vasectomy, or I've had a tubal ligation, or could we do a tubal ligation at the same time? The duration of the therapy isn't always known. So I always say that endometrial ablation is a great procedure when you're relatively close to menopause. We know that it's probably going to work very, very well for somebody who needs 2 years of relief, or 3 years of relief, or 5 years of relief. It may last 10 years, it may last 15. But the farther you are from menopause, the more likely that tissue is to regrow. And so unfortunately, if you're young, done having kids, let's just say 30 years old, have an endometrial ablation, if you have 20 years until menopause, there's a decent chance that over the course of that 20 years, that tissue is going to start to regrow. People will say, well, if that happens, can you do it again? And the short answer is no. We don't ever repeat the procedure just because of the scarring within the uterus. Option 5, hysterectomy. What is a hysterectomy? Well, everybody knows what a hysterectomy is for the most part. A hysterectomy is removal of the uterus surgically. But But what also gets included in the definition of hysterectomy? Well, a lot of people think that the ovaries are always removed, right? People will come to me and say, well, doc, I don't want to, people say all kinds of things. I don't want to start growing facial hair. I don't want my voice to deepen. I don't want to start having hot flashes. Well, having a hysterectomy doesn't cause those things to happen. Removing the ovaries might cause hot flashes, but just removing the uterus isn't. And in the great majority of women who are having irregular bleeding, we do not remove the ovaries. We really don't remove the ovaries unless there's a significant family history of ovarian cancer, or if somebody's so close to menopause that it doesn't really make a difference. The reason to remove the ovaries, of course, is prevention of ovarian cancer. But if you're otherwise premenopausal, meaning not yet in menopause, research shows that you're much better off to leave the ovaries. So hysterectomy is removing the uterus. It usually also means that we remove the cervix, which is just a portion of the uterus, and the fallopian tubes. Disadvantages of hysterectomy. It's a major operation, right? It's removal of an organ. So that carries risks, as all surgeries do. Risks include bleeding, infection, injury to other organs. Typically, there's a recovery period of about 2 weeks off of work after a hysterectomy, and about 6 weeks until you feel like you no longer had surgery. Typically, with a hysterectomy, patients will spend 1 night in the hospital. Cost can obviously be a concern, as a hysterectomy or any operative procedure isn't cheap. And then there's an emotional impact for a lot of women of losing their uterus or losing their fertility. Advantages. It's the be-all, end-all, really, of uterine bleeding. So the thing I'll tell my patients is, here's what I'll guarantee you. You will not have uterine bleeding after you take out your uterus. Sounds simple, but it's true. Really, with the first 4 options, I can't guarantee anything. I can't guarantee you that you're going to have no bleeding. I can't guarantee you that it's going to work. Probably going to be effective. But with a hysterectomy, I can guarantee you that you won't have uterine bleeding. It's a common surgical procedure. It's something that we do weekly here, and it's relatively low risk, although of course there's always a risk to surgery. There's minimal to no effects on hormones or sexual function after a hysterectomy. Hysterectomy eliminates really the risk of reoperation. So what I mean by that is, we talked about the endometrial ablation, and over time it could fail, requiring me to have to go back and do another procedure. Really, with the hysterectomy, there's no risk of reoperation of the uterus, obviously. Hysterectomy is protective against endometrial or uterine hyperplasia or cancer. There's a high rate of patient satisfaction after a hysterectomy. Most patients are very happy not to have any bleeding. Hysterectomy will not fail over time. And there's really no prolonged follow-up. I'll typically see my patients back at 2 weeks and then again at 6 weeks. But after that, you're pretty much done with the gynecologist. You don't even really need PAPs anymore because you don't have a cervix. So, you know, 6 weeks and you're done. There's lots of ways to do a hysterectomy. Far and away the most common way that we do it here in Hudson is what's called laparoscopic hysterectomy. That means that we make small incisions in your belly, with the first one being in the belly, just below the belly button, and then one on each side of the belly button. Through those incisions, we put a camera in one, and then we use an instrument on each side to kind of perform the surgery. I just have a couple pictures here of what an actual hysterectomy looks like. This is kind of the view that we have when we're performing a hysterectomy. So again, imagine standing at the belly button and looking down into the pelvis. That's what you see. This one's obviously labeled with the uterus, the fallopian tubes. Here you can see the right ovary. Here you can see the left ovary. But that's a very normal looking uterus and tubes and ovaries. And then again, using instruments, we can basically coagulate and cut as needed to get the uterus out. Ultimately, the uterus comes out through the vagina, right? So people will say, how did you get my uterus out of that 1 centimeter incision? And the answer is we didn't. By taking out the cervix, it creates an opening in the back of the vagina, and then everything will come out through the vagina. So the largest incision is actually in the back of the vagina, and that's the one that takes the longest to heal. And so we'll typically say 6 weeks for things like intercourse after a hysterectomy procedure. this is just what it looks like afterward, which again, I know it's kind of hard to see, but kind of the reason I said this is people will often say, well, what happens to my ovaries after you take out my uterus? They're still there. They're still attached to the side of your pelvis. They're not floating around. They're just what we call orphans. They no longer have a hysterectomy to play with. In summary, abnormal bleeding is common, occurs in about 10 to 35% of all women. You and your doctor can decide which diagnostic tests are most appropriate for you. There are multiple causes of abnormal bleeding. Most are benign, meaning non-cancerous, and all are treatable in one way or another. There's no right option for everyone. There's no right treatment option for everyone. And only you can decide, really, what's best for you after weighing the advantages and disadvantages of all the appropriate options. Thank you. Does anybody have any questions?